Good afternoon, everyone. In 10 minutes, I have to cover a topic, so we'll just rush to that. So, what are the various types of diabetes that you find in children? So, mostly we talk still majorly type 1. But yes, there are random cases where you have a dicey diagnosis. Is it really type 1? Maybe. Anybody coming to you around, say, 2025 with a strong family history and a dysglycemia or a moderately high sugars, probably you'll give the benefit of doubt, say it is monogenic diabetes. But what about overweight children with frank symptoms of acanthosis, altered periods, acne, hirsutism, PCOD girls maybe, and a strong family history of type 2 diabetes? So that is the group we are discussing here. So what is the present scenario if you talk of? You will find that anybody with type 2 diabetes before the age of 25 is nowadays having a new Christian name of youth onset type 2 diabetes, that is YOT2DM. What is the incidence? They are on the rising, I would say. Not exactly quoting in terms of numbers, but they are rising. If you look globally, it is not the Indian scenario, it's a global scenario. If you look globally, you will find almost across the globe, pan-globe, the number is rising. These are data comparing the percentage from 2013 to 2017, and the data is rising. Now, this is an article which has been there in the CDC government diaries, which says that the pre-diabetes is still higher as compared to type 2 diabetes. And pre-diabetes, as we know, is just a forerunner of type 2 diabetes. So the percentage of pre-diabetes in youth is almost 20 to 25%. So this is exactly what Sir Dr. Nishal was talking, that this is how the children look nowadays. They are obese, overweight, and have a strong family history of type 2 diabetes. So the type 2 diabetes is actually mirroring or mirror image of obesity in the young. So obesity is also on the rise. Say, let's see, this is the child sir was talking, probably visiting his pediatric clinic just for cough and cold. Parents never mentioned that the child is overweight. So do you think it is just a cosmetic problem? Obesity, is it a cosmetic problem? I would say no. Obesity in childhood can have far-fetched consequences. Child might be just left out in the classroom, child might be psychologically disturbed, but we are here concerned with the endocrine complications. We are talking about the type 2 diabetes in the youth. So how do we actually diagnose pediatric obesity, or when do I say that my child kam khata hai lekin thoda mota hai? How do I say? Every mother feels my child does not eat. So whenever a child is attending your clinic below the age of 18 or even 15, I must say for that matter, always monitor height and weight, and please plot them on the respective color-coded graphs. So these are the IAP charts, WHO charts. Use any charts, but please use charts. And according to these charts, you will define that the child is overweight. So 85%, more than 85% of the BMI is overweight. More than 95% of the BMI is obese. Now, are you measuring waist-hip ratio? Why should we measure waist-hip ratio? Chubby child, people like chubby child. So we should measure WHR because your waist should always be half of your height. You have to remember the visceral obesity, the YY paradox. This is the picture of our own Dr. Yajnik. You will see him tomorrow in this very hall, in this very Diabetes India. He will be coming tomorrow. He will be having a talk tomorrow. So this is his own paper where he has the same BMI, but the visceral adiposity was significantly higher. So please measure not only BMI, not only waist-hip ratio, but also keep an eye on the visceral obesity or the visceral adiposity. So whenever you measure the adiposity or the WHR, please plot on the waist charts, and if they are more than 70th percentile, please evaluate. So why are we insisting on growth charts so much? Because endocrine cause of obesity will always be coupled with a short stature. If a child is having tall stature with obesity, we are dealing with nutritional obesity, and this child will be type 2 diabetes patient tomorrow. So what are the underlying causes? Pointers, obesity with height less than 3rd percentile, obesity with growth velocity less than 25th centile, obesity with precocity or delayed precocity, obesity with delayed bone age, or obesity with any focal deficit, that is any syndromic picture. Okay, now how did we get here? हम यहाँ तक पहुँचे क्यों? One important factor is the placenta. This ephemeral organ has long consequences, be it the thrifty gene hypothesis of undernutrition or be it the overfed child. Both the children will ultimately lead to obese childhood, gestational motherhood, and finally another type 2 adult. So children with obesity, what are the various risk factors? We have many, beginning with family history, because the family that eats together will have the same anthropometry or will have the same BMI or waist hip ratio. Then family history, genetics is there, then in utero life is there. And of course, nowadays the screen timing are so high that we don't have physical activity in our children's lives. Then the safety of the environment, the societies have become so unsafe that we can't allow the child to go out and exercise or walk or cycle out alone. So the walkability of the environment has been challenged. So this is leading to youth onset type 2 diabetes with all the risk factors. This is intergenerational transmission moving from in utero life to the type 2 adult. So is the pathophysiology of youth onset type 2 different from adult type 2? It is as complex as in adulthood, leading to early complications. How is it different? One important factor, their asymptomatic gap period is much less. So children quickly land up with hyperglycemia. And as they quickly land up with hyperglycemia, they have a long life to live with type 2. So they are bound to develop microalbuminuria in almost 100% cases, blindness maybe in 20%, and a decreased lifespan of around 15 years. Complications develop much earlier in children. They develop nephropathy within 3 years of diagnosis of type 2 diabetes. All the other complications of any type 1 versus type 2, you will find that the type 2 children have all the complications much higher than type 1 diagnosis. So what different do we need to do to prevent it or diagnose it? You must start screening. So whom to screen? Anybody with the risk factors. When to screen? After 10 years. How frequently? Every 2 years. How to screen? With fasting plasma glucose. So anybody, any child overweight with 2 risk factors, please start screening. So these are the various risk factors. You come across a child with acanthosis, with hepatomegaly, family history, dyslipidemia, hypertension, a very eye-opener. A child with high blood pressure, even on the high normal range. Then ethnicity, of course. Fundus, if you are examining, you might find papilloedema. So what are the basic tests that we ask for? Assess for cardiometabolic risks. Assess for the presence of comorbidities, and individualize when you are suspecting endocrinopathy. So what are the diagnostic cutoffs? They are just the same. They are not different. Same, fasting plasma glucose above 126, HbA1c above 6.5, and 2-hour plasma glucose above 200 or 11.1. So the diagnostic cutoffs are just the same. Target, we try to keep the HbA1c below 7 as per the ADA guidelines. How do we manage this condition? 1.5 minutes left. Begin with lifestyle modifications, of course, dietary interventions and physical activity. We need something at school level, family level, and of course some molecules. So take a detailed history, dietary interventions, family counseling, because you can't leave the child out. The family has to eat whatever is being given or served on my child's plate. Exercise, again, a family atmosphere has to be developed for at least 30 minutes every day physical activity with vigorous, intense activity at least thrice a week and endurance exercise as well. Pharmacotherapies to target insulin resistance, hirsutism, dyslipidemia and hypertension. Again, a very interesting scenario when we have a bundle of molecules to treat type 2. We have very limited choices when it comes to children. It is metformin and GLP-1RA. The regime is whatever the diagnosis, you first begin with metformin and lifestyle unless it is DKA. Second molecule you choose is GLP-1RA because which is approved above 12 years of age. And third molecule is always insulin. So you don't have much choices. We are trying nowadays with SGLT2I, yes, but off-label. Pioglitazone again off-label and might again put on some weight, but it will improve your MESLD or NEFLD. Bariatric surgery is the last choice. Weight reduction goals around 0.5 to 1 kg every month. As long as the child is gaining height, you still have a chance that, okay, weight can be covered up, but otherwise you need to lose, as the adult case, that is 1 kg per 0.5 to 1 kg per week. So the children are much resilient. It is the family that needs to be counseled. Prevention policies by government, schools, as well as families. So this is a summarizing story. Type 2 incidence is rising. Complications are at much higher as compared to type 1. Drug choices are limited, metformin, GLP-1RA, SGLT2I. So prevention is the key. Catch them early, plot them meticulously, investigate them aggressively, medicate judiciously, expect results minimally, accept denials, but be motivating. We are together here. It might be challenging, but it is worth the efforts because inaction will have devastating results. Thank you.
Thank you so much.